My name's Dr. Nate Estrin. This is my lovely assistant, Kim Strouderman. She has been with me for, how long have you been with me now?
Ooh, since September.
Since 7 months.
Not a whole year yet.
Not a whole year yet.
Nope.
So I was a traveling periodontist for a couple of years, working with a lot of temp assistants, a lot of different assistants, different offices, different types of practices. Very, very stressful. Kim has made my life a lot easier. She travels with me everywhere, and as we've localized more and more to a perio referral office, Kim has stayed the trek. So
I try.
you're doing good.
It's fun.
So I want to talk to you about phlebotomy and PRF. When you first started with me, you'd never done phlebotomy.
Never.
Right? Never. And now you're like a pro, and in just about 7 months, sticking every patient. Do I do PRF on every patient?
You do.
Okay.
Just about.
Okay.
Small percentage you don't, but
Small percentage.
Usually
but yeah.
blood draws for every surgery.
But have you noticed, because you did a lot of surgery with Dr. Cantor, and we just spoke with him today, and he was doing all these surgeries before PRF.
Yep.
Do you notice a big difference?
Yes, especially with the grafts.
Yeah.
Like the gingival grafts, because before in the palate, the patients would come back like 2 weeks later for their post-op, and that area would still be red and, healing, still open. Then when I first started working with you and I saw the PRF on the palate, and then the patient came back for a 2-week post-op check, it was almost already closed up. So it was pretty mind-blowing. I'm like, wow, it really works.
And you had been doing how many years for gingival grafts with Dr. Cantor without PRF?
Since 2004.
And first case, you notice a big difference?
Yeah.
Yeah. I mean, PRF is just the best.
Yeah, working with you and the PRF and all these new things, and you're constantly teaching and, continuing education with, PRF EDU and, taking me to courses there. So I've learned a lot, and you really put a lot into continuing education to help your patients, because you love it, and you love providing the best for your patients and giving them your best. And you have a great bedside manner, and you're very comforting. Multiple patients have said it. They say he's so soft-spoken, so they feel very comfortable in the chair.
And that's why you stuck with me.
That's right.
That's why you're here.
That's right. Not going anywhere.
Good. We have fun. You have to put into a lot of work into continuing education.
Yeah, you do.
But you do too. You go to the courses and you learn more about PRF. And it'll get better. I could probably spend more time, showing you things. Sometimes it can be so busy in clinic, I don't take the time to explain the why a lot. But you do a good job of asking questions, and we do have slower days and days where we can catch up and things click. And I'm just, we've grown so much as a team in the past 7 months. I've seen you grow from not phlebotomist to now you're teaching course on PRF. We're going to these offices, or people are coming into our office, and you're teaching other assistants, you're teaching other clinicians how to do PRF, how to make sticky bones. So it's pretty cool. It is a game changer, and I think that you see it. I think all the staff members see it. Yeah.
And with the PRF, like today, we had that patient who we were working on where we took out a tooth on him and did a bone graft, and we got the medical clearance back, and the doctor did not want him to stop his blood thinners. So it's like, what do you expect? You think he's going to be bleeding all over, right? So it wasn't much at all, and that PRF just stopped everything. So before he left, there was no bleeding.
And that was, we harvested from the palate?
No, that was just number 5, the extraction and bone graft. Yeah. And there was no bleeding at the end,
but
and he's on a blood thinner.
Even the palate, right? Even when we harvest from the palate, there's a ton of bleeding. You put the solid PRF.
Yes, as soon as you put that on.
Slowly, 2 minutes later, trickles. Yeah,
Yep.
I know. It's amazing.
Yeah, it does.
Yeah.
It's great.
So it's changed my life for sure.
Yeah.
Yeah.
And just other things like Cleveland Health Lab with, testing patients' blood. So, we have them come in the morning fasting and, draw their blood, send it out to the lab to be tested, because their diabetes plays a big role with, especially if you're going to have implants placed, or if their D levels are off, or magnesium, or whatever.
That happened naturally. It's not like, it's some light bulb idea popped into my head or anything like that. It was something that patients asked for, right? Patients are coming in where you're drawing their blood, and they're asking you, oh, can you check my blood sugars? Can you check my vitamin D while you're doing it? And then it just evolved to, why don't we?
Yeah.
We know that periodontitis has a strong systemic relationship, You know, and we see the same type of patients in the chair all the time that are overweight, have a bad lifestyle, smoking, diabetic, right? And it's no surprise that they have gum disease.
Yeah.
So gum disease is just a side effect of systemic inflammation, chronic systemic inflammation, and that's why it manifests later in life. So just something very cool about these blood draws, patients don't see their physician as often as they see their dentist. So they see their dentist probes, they have deep pockets, they get sent back to us. Okay, we do our Quest diagnostics, we draw their blood. A lot of them have been pre-diabetic and they didn't know it, right? So we'll give them their blood test results and send them to their physician, and that to me has been, you know, probably the most critical part of our practice and doing phlebotomy in the dental office, is that we've been able to help patients and give them so much more information about their systemic health. It made me better being a traveling periodontist and working with temp assistants who don't really care about the outcome of the procedure, and they just want to put in their hours and leave. And you know, Stony Brook University, we had unionized workers, so the assistants would leave 5 p.m. whether you're done or not. And you know, even though those were the most frustrating moments in dentistry, you know, you can imagine when you're suturing and doing surgery and you don't have help, you know, it does make you better. You know, I always believe that the harshest environments make the best surgeons. So that's why, you know, I use bare basic equipment, 15 blade, needle holder, nothing fancy.
You do. You can make
Yeah.
anything work.
Yeah,
I've seen it.
that's-
I'm like, he is the least picky
Yeah.
person. He makes anything work.
Because I've been in situations where you have to,
Yeah.
where you don't have something to reflect
Yeah.
with, or you don't have the equipment you need. Even though that's scary now, you make it work. But when you came in, you made everything so much easier right off the bat.
Thank you.
So your first day, I don't know if you remember this, but you came in and I didn't know what you were going to be like as an assistant, and you sent me a text message. You said, all your scripts for Tuesday have been called in, your schedule's been changed, and all of today's post-op patients have been called. Everything that normally would like bother me and I would have, you know, to do after clinic hours, you just handled it and sent me a text message, and
Yeah.
that's when I was
I
like,
remember
okay.
that.
Yeah, I know. And that was a big help, so thank you.
You're
Thank you for
welcome.
continuing to do that for me,
Yeah.
for us.
Yeah. Well, I enjoy working with you, so you make it easy.
Remember when we first started doing the EPRF cases, and it was taking so long for those membranes to set up, and it was, you know, there's this big dilemma, how are we going to do this EPRF, which takes forever,
Yeah.
okay, and apply it to a faster paced peri office, which we're at now.
Yeah.
Okay, it was like mission impossible. Now, when we don't need to wait for the EPRF membrane to set, it's way more manageable. You know, especially you've got multiple staff at that office. We've been able to use PRF as a way to stagger our surgical appointments, so we can run 2 surgery columns at a time. Because PRF kind of breaks up the appointment, right?
Yeah.
You know, you're in there drawing blood if I'm not free first for anesthetic. So the patient's getting treatment in one room by you while I'm in another room with a different assistant.
No, that's true, because, you know, we're in there drawing blood. We're taking blood pressure first and all that stuff, and then drawing blood and
Drawing
talking to
blood.
them calmly and, you know, making sure they're feeling comfortable, and then having to hold, you know, a lot of places tell the patients to, you know, bend their elbow and hold the cotton there. Well, no, we don't. We hold it there to close it up so they don't get a hematoma. And then, you know, taking it to the machine, of course, the PRF, and running it through. And that takes anywhere from 8 to 12 minutes,
Right.
depending on what setting.
During those 8 to 12 minutes, right,
Yeah.
we can start working,
Yeah.
okay, they take the tooth out,
Yep.
patient can finally relax, okay, can relax. Now I'm in a different room doing a different surgery, okay, and you're staying in the room, making sticky bone, making the EPRF membrane, making all the materials that we need. So we've been able to make it work just by staggering our surgical appointments and run 2 surgery columns. So PRF has just been the perfect excuse for me to leave the office. Patient still gets treatment done, you know, by you or a different assistant, and it's been great, you know.
Yeah, it works
It's been
well.
the perfect way to break up the appointment.
Yeah, I agree.
You know, patients have a big misconception. They believe there's a linear relationship between time and bone loss when it comes to gum disease. But it's not a linear relationship at all. It's actually exponential. Okay, so you may have had deep pockets for a few years, okay, where a 4 millimeter pocket becomes a 5, becomes a 6, but it gets exponentially worse. It's very easy for a 6 to become a 7 or a 9 in a few years, okay. A lot of patients, they go to peri office and they find out they have deep pockets and know it's bad, but they don't really understand exactly what it means. Okay, when we're measuring or shouting these numbers, we're measuring your pocket depth. It tells us how much bone loss you have, but it also tells us what type of environment you have in your mouth. Okay, a deep pocket has a more anaerobic type of bacteria. Anaerobic meaning no oxygen because it's deeper in the pocket. Okay, so that's that bad type of bacteria that causes an inflammatory response. So we have a deep pocket, anaerobic bacteria, an inflammatory response. You lose bone. What happens? A deeper pocket, a worse type of bacteria, more of that anaerobic red complex bacteria. A deeper pocket, more inflammation, more bone loss, deeper pocket, worse bacteria. And it's this positive feedback loop that ultimately ends in tooth loss. So we have patients all the time, they've got deep pockets. Okay, they say, oh, I've had deep pockets for a few years. It can very quickly become ugly, you know, where you're losing multiple teeth. You're going through a whole mouth rehabilitation. Those are patients that I feel for because I feel like they were maybe innocent, maybe not as educated to make the right decisions and address their gum disease when it's easier to address.
Right.
Yeah. So to follow up on that, clearly you see a difference when we're doing surgery on moderate periodontitis versus severe periodontitis.
Yeah.
Like how big of a difference do
Well,
you see?
during surgeries, when they have there's a lot of bleeding going on with the granulation tissue that's in there, that diseased tissue. It's a huge difference.
Huge difference, and
Yeah.
it's way messier. The
Yeah.
appointment time takes
Yes.
4 times as long
Yeah.
for severe perio when moderate. Moderate, we're done
But very
quickly.
satisfying when you're doing
Very,
it.
no,
As
always
as
satisfying.
you're cleaning those
Always
teeth up
satisfying.
and you have the flaps open, you just see these ugly teeth, I'm just going to say, with tartar and everything else going on there. Then we're done. They just like bling, like a beautiful little tooth there, and you just suture it back up, and they look good.
Yeah.
And the thing I like about working with you too is you're conservative. So if there's a tooth that may be borderline, you're willing to go and do these deeper cleanings first to see how these teeth react without just going, oh, you're just going to lose it. Because some of these people can have them for quite a few more years and get more use out of that tooth. And that's one of the things.
If we're doing, the way I look at it is if we're doing osteosurgery anyways, we might as well wait and see how the tooth is going to respond. Even if there's a 10% chance, you know, it's more work for us.
Yeah.
But we've been relatively surprised by some patients.
Yeah.
Even if they hold on to it for a year longer, 3 years longer, you know, it's a win.
Yeah.
So, you know, we only take out teeth if there's a 0% chance.
Right.
You know, and then, you know, and that's because having those deep pockets there will affect and could hurt the other teeth.
Yeah. And the other thing I love learning and being in perio is, you know, besides, you know, as opposed to being in general, is when there is a tooth with deep pocketing and you cannot save that tooth, and that deep pocketing is starting to affect that tooth in front of it a little bit, and that tooth also has a little bit of a deep pocket. You'll go in there and take out, let's just say it's tooth number 2. You'll take out that tooth, and then you clean it all out, and then you do the bone graft, and that bone graft helps save tooth number 3.
Right.
Because you're just rebuilding.
Yeah. And which one's more valuable, 2 or 3?
3.
3 is 10 times more valuable.
Yeah.
So, you know, and the way that I explain it to patients is we're cutting off the diseased finger to save the hand. Okay, you're not going to miss a second molar as much as a first molar. And by cutting off that diseased finger, that second molar, we're going to buy a lot more time out of our first molar. So one more thing that I'll say about the pocketing is that there are certain critical points where your teeth start going downhill much faster. Okay, number 1 is when the tooth starts becoming mobile. Okay, when a tooth is mobile, the body recognizes it as foreign, and we start losing bone loss much faster. The other thing is furcation involvement. So when I say furcation involvement, molar teeth have multiple roots. So when that bone loss exposes the crotch of the tooth where those roots separate, it becomes a very harsh environment, very difficult for both the patient and myself to clean, and teeth start going downhill much faster. If you had a dental surgery by me or by someone else, okay, one thing that you want to do is let comfort guide you. All right, a lot of it is common sense. If you're brushing, if you're eating something and it hurts, don't do it. Don't eat it, don't brush that way. Okay, the more you baby it, the better it will heal. But you can't neglect your home care. I don't want to see you at 2 weeks and you haven't brushed at all. Okay, that's not going to help the healing. Okay, that's going to make it worse.
And we see those.
And we see that a lot.
A lot.
We see it a lot. So that's probably the biggest misunderstanding with post-op instructions, even when we tell them or write on the instructions.
They come back with plaque
and
cover.
I don't blame them. They just had surgery in their mouth. They're scared to brush.
Yeah.
But, you know, you want to let comfort guide you. So day 3, you'll start brushing your teeth. day 4, day 5, you'll start to brush it a little bit more thoroughly. But then by 2 weeks after osteosurgery, you're back to normal brushing.
The other things that I notice helps these patients a lot is Stella Life.
Yes.
The rinses and the
Game
gels.
changer.
It really is.
Kelly, she has it in her first aid kit.
Yeah.
You know, she rubs it on her cuts and her skin. It helps with everything.
I told you, my friend, her daughter had her wisdom teeth taken out. And she was like, Kim, what can I do? She's in all this pain. It's like day 3 out. And I'm like, nothing really. I mean, unless she has a dry socket, get it checked. But you can try Stella Life rinse. So I took her a kit home, and her daughter started using it. So I asked her the next day, how's she feeling? She's like, she's feeling good. She's not complaining or anything. And
It works.
so her daughter said, yeah, Mom, that stuff helped. And no issues.
It
So,
works. And there's literature to support it because the active ingredients in Stella Life have been very heavily researched. It's all homeopathic ingredients.
Yeah, which is nice.
But regardless of the research, it just works. We have
Yeah.
patients that come, they buy more, you know, they use it as a mouth rinse continuously for the rest of their life. I mean, it's just a fantastic product.
It is.
Do I use lasers?
Yes.
Do I do conventional surgery?
Yes.
Both?
Yes.
On every patient?
Not on every patient.
I mix and match? Yeah, exactly.
Yeah.
Yeah, so, you know, my master's thesis was all in laser therapy. I'm a big supporter of lasers. I think they're an amazing adjunct, but they're not a complete replacement to conventional surgery. They just don't penetrate deep pockets, and they don't assess deep pockets as definitively as conventional surgery does. So I do combination therapy. Okay, we do conventional surgical therapy in your posterior teeth and your back teeth, and then laser the rest. Okay, and that allows us to predictably assess your pockets, all right, and minimize the amount of surgery that you need. And that's where we see great results. Okay, we're not going to do surgery the whole mouth if it's not needed, only the parts that are too deep to be fully assessed by a laser.
Right.
One of the myths about PRF when I go to these courses is that clinicians will say, oh, you know, if the patient's too sick or too unhealthy or their medical history is too complicated, I was told not to do PRF on them. You know, they're not going to have great regenerative potential, and that is completely false. Okay, the only contraindication to PRF is cancer, because I don't want to take cancer cells from the patient's blood and put in their mouth. But the way that I explain it to those clinicians is, let's say you have a cut on your hand. Okay, the first thing that happens is what? Blood clot, wound healing. Okay, so all of us have this regenerative capability inside of us. Okay, and if your regenerative capabilities are so diminished that if you get a cut on your hand, you won't regenerate and heal yourself, then we shouldn't be doing surgery on you.
Right.
We shouldn't be placing an implant or doing a bone graft or anything else. Okay, you're too medically compromised.
Right.
So if the patient's healthy enough to do surgery, they're healthy enough to do PRF, period. Because I do think that probably one of my best surgical skills is suturing.
Yes.
You know, that's definitely like something that I take pride in is suturing. You know, it's just, it's got to be.
When I
Well,
first,
it's more-
I
it's the
first
most
started
important.
with you and I saw you suture, I was like, holy cow. Like, he is a master suturer.
It's
Hands
every,
down.
well, I'm a periodontist. So
Yeah.
that's it. All periodontists are good suturers, period.
Wow.
You know, we go through extensive training on
I was
how
amazed,
to suture
so.
appropriately. Yeah. Well,
You
thank
do a nice
but
job suturing.
It's the most important part, and it can totally change the outcome of the surgery.
Yeah.
You know, you can have special sutures to coronally advance the flap, apically position the flap, you know, and adjust your outcomes just based on how you stitch. You know, it's pretty amazing.
Yeah, and I would have never guessed you could do all that with a stitch. But since working with you, now I see all these things, how the tissue just pulls together and you pull the sutures. I'm like, oh yeah, look at that.
Yeah, it's
cool.
definitely important. Yeah. So during COVID, we were shut down for a couple months in New York, and that's where I did a lot more research, published those laser articles, published a cone beam study, and practiced suturing. Went through every surgery in my head, how to do it, sutured over and over again. You know, first on a banana, okay, then you step up, you eventually get to a grape. You know, that's very hard to suture, and that's like really how you build skills. So, you know, I always tell clinicians, if you want to become a better suturer, you just have to practice outside the mouth. Okay, and that's especially important with gathering. You know, I don't like to have the needle drape over the patient and dangle over the patient's head. I think that's really like unprofessional and not classy at all. How do you explain PRF to patients? Like patient in a chair, and I go, oh, PRF? What's PRF?
So I tell them it's called platelet-rich fibrin. I tell them it's nutrient-dense material that we extract from your blood and replace it back in your body. So when we're doing a bone graft, we take that nutrient-dense material that we get from your blood, put it in our bone graft material, and that goes back in to help promote healing and help clotting.
Well said.
Yeah.
And then one thing I'll say about PRF, when you start doing PRF and your staff sees the results post-operatively, that's when your staff believes in it, that's when it'll start becoming adopted by your practice.
Yeah.
So the best advice is to start doing it on extraction sockets, start doing it on things that heal by secondary intention. Okay, your staff will really see the results, and then they'll become believers, and they'll start getting case acceptance from patients, because when they're talking to patients about it, they really believe in it. They'll say, trust me, you want this, it's going to heal better.
Yeah.
So can children get gum disease? And yeah, it's rare. You don't see it as often as we used to. It's not your classic periodontitis where you've had a lifetime of systemic inflammation and now we're seeing, you know, gum inflammation as a side effect. Okay, a lot of times I'm suspicious that there's something systemic wrong with that child. Either there's something wrong with their immune system, whether it's neutrophil chemotaxis and white blood cells aren't getting to the pocket to fight off the bacteria, or something else, some genetic abnormality, but it's definitely a lot more alarming when a child gets gum disease. We do IV sedation at the office with a nurse anesthetist, okay, so that we've got two pairs of eyes looking at you. We also do oral sedation to anyone that wants or needs it. Ultimately, the decision is up to you. You know how you're going to be in the chair more than I know. You know, I can make some assumptions when I meet you, and I can always offer it and engage your response. But ultimately, you need to make that decision if you want sedation or not. If you have gum disease, okay, the first thing that I want you to understand is that it's not your fault. Okay, there are other patients out there, other people out there that brush the same way as you, or lack of brush the same way as you, and they don't have gum disease. So there is a genetic predisposition to it. But since you know you have gum disease, you have an increased responsibility to assess it, okay? And that's everything in the kitchen sink. Brush, floss, mouthwash, non-alcoholic mouthwash, a proxy brush, and water pick, okay? Another thing about a water pick, a lot of our patients, they get this nice tingly feeling from a water pick where they stop doing some of the other things, and that's not good, okay? That's a false feeling, okay? A water pick is a good adjunct, but not a replacement. You always want to use a soft bristle toothbrush, okay? You won't hurt your gums if you're nice and gentle with your brushing, nice circular motions. I always tell patients 50% of the bristles on the tooth, 50% of the gums. The tooth surface is really smooth, so all the plaque happens right along the gum line. Okay, so you want to really engage your gum line. You have to engage your gum line, and if you're gentle and use a soft brush, you won't cause damage to your gums. Diabetes is a blood flow issue. Okay, right? That's why the extremities are the first to lose sensation and are the most effective oftentimes, as well as every organ really. But it's a blood flow issue, and periodontal disease is a blood flow issue as well. Okay, the periodontal ligament is very vascular. Okay, so when the blood flow is compromised, okay, where you start to see a lack of support, lack of blood flow, increased bone loss, loss of periodontal structure, and ultimately gum disease and tooth loss.
Just tell them. Just pretend we're not even on camera right now.
We're not.
Just tell them.
We're not.
We're not.
You know, I'll say when I first graduated from perio residency, I'll never forget what my mentor told me. One of my perio professors, Dr. Pappas, he taught me how to suture. He taught me a lot of things. But he told me when you first graduate, you've gone through all this schooling, all this education. You're going to feel like you're on top of the world, but you're really at the bottom. Nobody knows who you are. Nobody knows how good of a surgeon you are, what you can do. You're starting from scratch, and you have to prove yourself. You know, and so we do that by knocking on doors, both me and Kim. And before Kim, I was doing that myself. Okay, so I'm knocking on doors, delivering cookies. You know, I'd take a day off of clinic and patients and literally deliver cookies to dentist offices. And this one day, hot summer in Florida, I'm delivering cookies all day long, and I'm on the last box of cookies, and I think, you know, I've been I've been giving out these cookies all day and I don't even know what they taste like.
This is the
So
best.
I have a chocolate cookie. Okay, and it was fantastic. So I was proud of myself for giving out good cookies. I have another one and I have a third one. And I look at the box and there's chocolate all over the box. Okay, no problem. I have a water bottle. I have paper towels in the car. We clean up the box. We make it look like, nothing happened. And I walk into an office and I deliver cookies. And me and the dentist hit it off, I thought. We talked for an hour and a half. I'm telling her, oh, I work for Pure FEDU. I travel all over the country, big shot periodontist. I'm showing her videos and surgeries, and she's all impressed. And she's like, oh, I'm going to send you my sinus lifts and X, Y, and Z. And I get to my car, and I look in the mirror, and I had chocolate all over my face.
That's the
And
best.
I was just in shock.
That's
Like, it
great.
took me sticker shock. Took me like a minute. I had to rethink how the last hour and a half went. I just about shit my pants. So, but it's part of the process. You fall forward and you just do the best you can and move on.
That's great.
So,
That's one of the best stories ever. I love that story.
and yeah, safe to say she does not send me patients anymore.
No.